for fasciotomy, which is considered to be a practical indication for performing fasciotomy, it is a clinical suspicion. Alright, just when you are suspicious that the patient could be suffering from compartment syndrome, take the patient in the emergency OT and perform fasciotomy as early as possible. Hope everything is clear related to this topic. Now we are going back to a sample question where you have to identify two very important things. One, the etiology, and relate it with the positive clinical findings which are provided to you. So the question is that patient with the fracture of the both bones right leg was admitted for surgery with the above knee slab. Third day on rounds, professor noted excessive swelling in the toes, and on extension of the toes, patient experienced intense pain. That means you have already made the diagnosis that the patient is suffering from compartment syndrome. Now what next? As I told you, majority of the questions asked in relation to this compartment syndrome management are going to be utilizing your common sense. So first option is measure intracompartmental pressure. Obviously not. Why? Because already you are aware that the patient is in compartment syndrome. Why to perform this measurement? Second, perform close reduction, internal fixation. No, first you have to save the limb. You don't have to fix the bone. You don't have to think about fixing the bone first. First, you have to save the limb. Limb salvage should be your priority. Third, perform fasciotomy, because it is already third day the patient has sustained injury. So from the time of injury, it has to be 6 hours in order to have the best possible outcomes of fasciotomy. So fasciotomy immediate at this point is also not going to have a favorable outcome. So what next? Remove slab and start appropriate antibiotics. Yes, obviously that is the correct answer, because compression, extrinsic compression could be a reason. You have to remove it. You have to decompress the entire limb and then subject it to appropriate antibiotics and anti-inflammatory drugs in order to prevent the cellulitis from developing or gradually progressing into compartment. So hopefully what we are expecting that you are aware everything related to compartment and you would be able to solve any question asked in pertinence to this particular topic, that is compartment syndrome. That is one dreadful complication which is avoidable, remember. Next, before we come to the next topic, let's have a sample question. Now what are the things which are provided to you in the question? 1. A young male admitted with a fractured right femur, right tibia and fibula with the fractured left femur. So bilateral femur fracture with the fracture in the both bones of the right leg. So multiple long bones are fractured, which is a etiology provided to you. Next, he developed fever and increased respiratory rate. So when he was admitted, there is increase in the respiratory rate and there is a fever. On examination, he was found to have petechial lesion over the trunk and abdomen. So just by reading the entire length of the question, you should be able to reach the diagnosis. And then whatever are mingled in the form of the options, you have to rule it out one by one. Alright. So the topic that we are talking about is the fat embolism syndrome. So first of all, how this etiology is responsible for causing this fat embolism. Imagine if this is a long bone in this age group of more than 20 years where the medullary canal is replaced by a fat. Then if there is a long bone fracture, then these fat globules will be out of the medullary canal and there is a possibility that it might reach the circulation. Once they reach the circulation, it might impede or it might go all the way into the pulmonary circulation, leading to dreadful complications. But if multiple bones are fractured, then the possibility of these fat globules present in the circulation will be increased multiple folds when multiple bones are fractured. That is the reason always will be provided to you in the form of etiology as a hint is multiple of fractures in multiple long bones. Alright, this is how it is provided to you in the question. Like polytraumatized patient having multiple fractures in multiple bones, because the possibility or probability which increases the possibility or a probability of these fat globules to reach the circulation. Second are the clinical features. Now, how you will identify that whether the patient is suffering from fat embolism syndrome or not is going to be based on the clinical features. You see, the alarming clinical features are fever, tachypnea and tachycardia. That means raised temperature, the increased respiratory rate and increased heart rate, these are considered to be the alarming clinical features. In case a polytraumatized patient is admitted in your ward and is having these kind of features, possibly he might be progressing towards the fat embolism syndrome. Second is the identification of petechiae, that means small bleeding spots over the trunk, abdomen, axilla, even on conjunctiva and retina. All right. So there could be a presence of these small lesions over the trunk, abdomen, axilla, conjunctiva or retina. All right. So these are the small bleeding spots, petechiae. And once you identify these petechiae over these regions, it is considered to be a pathognomonic, although not diagnostic, but pathognomonic finding for fat embolism syndrome. And eventually what will happen, that once it reaches the pulmonary circulation, then it might result in respiratory distress syndrome. So it might result in respiratory distress. Then once it is responsible for impeding the circulation to the cerebrum, it might result in confusion, then coma, and eventually death of the patient, or it might result in death of the patient. So just imagine a patient who was admitted with multiple long bones fractured might be a cause of ultimate collapse of the patient, that means death of the patient. So this is why this is a dreadful complication which is again to some extent avoidable. All right. So we have talked about the etiology, we have talked about the clinical features, and these clinical features will always be provided to you in the question so that you identify the question when you read the different lines in that. Then comes the diagnosis, that how will you diagnose the condition. You see, diagnosis is all clinical. There is no investigation which is considered to be the diagnostic modality of choice for fat embolism syndrome. If there is a presence of urinary fat globules, all right, and that too of the size of more than 10 microns, it is just suggestive of, it is not confirmatory or it is not diagnostic of fat embolism syndrome. Even this finding is just suggestive of that the patient could be having a fat embolism. It is not diagnostic. And finally comes the management. Now, what will you do in the form of a management, or how will you treat, or how will you progress with the management of these conditions? So as far as the treatment of this fat embolism syndrome is concerned, immediately put the patient on high oxygen. All right, high oxygen support has to be provided immediately. Then second steps are to be in order to deal with the stabilization of the fractured bones. All right, these are to be stabilized as soon as possible, because it is the persistent movement at the fracture site which is responsible for exporting these fat globules into the circulation. All right, so it has to be stabilized, and that stabilization can also be achieved by surgical fixation, which could be achieved by surgical fixation. All right, so you just go through perform a survey on the patient. If the patient is having a weak stability at the fracture site, he is not perfectly immobilized, then at least stabilize the patient by the placement of a sling, by the placement of the traction pins at least, so that there is no movement. Second, you can plan for surgical fixation as early as possible, because that is the reason for the export of the globules into the circulation. Now, there was one condition which was considered to be contradictory, or it was considered to be a contraindication in the management of fat embolism syndrome. Just imagine, you know, the treatment of a long bone fracture in the lower limb is internal fixation using intramedullary nails. All right, all of us are aware what the intramedullary nails are, and we have discussed when we were talking about the open reduction internal fixation techniques or fixation techniques. So one of the internal fixation device is a intramedullary nail, where the nail is placed inside the medullary canal and it is fixed with the proximal and the distal screws. All right. Now, in order to place this intramedullary nail, first you have to ream the medullary canal. create a space where this intramedullary nail could be inserted or advanced through the fracture site, and then it is fixed. Now, is it not a possibility that when you are reaming, when you are preparing the canal for this fixation, you are relieving more fat globules into circulation, or you are releasing more globules into circulation? This is also a possibility, and that is why it was considered to be a contraindication. But today, it is no more a contraindication, because the management, based upon the evidences, it has found that the advantage of performing an internal fixation is higher on the disadvantage of avoiding it. That is the reason why internal fixation with intramedullary implant is no more a contraindication in a patient where there is an expectation of a fat embolism syndrome. So you can write it down by putting a star, that intramedullary nail fixation, intramedullary nail fixation is no more a contraindication. So hopefully everything is clear. Although it is highly unlikely that the examiner will go to an extent of asking about the same, but now you are aware that it is no more a contraindication, which was previously considered to be a contraindication for obvious reasons. All right. So this is all about fat embolism. Now, what we are expecting, that how the examiner will progress in asking this question, is by giving you a key clinical finding, and then they will ask what is the condition the patient is suffering from. So if you look at the question again, a 26-year-old male, that means the age of the patient is beyond 20, admitted with bilateral femur and right-sided both bones of the leg fractures. That means multiple long bones are fractured. Now, he developed fever and increased respiratory rate. These are the two alarming clinical features which are probably mentioned in the question. On examination, he was found to have a petechial lesion over the trunk and abdomen. It almost confirms your finding of fat embolism syndrome. Now, which of the following is incorrect for the situation? Now, if you look at the option number 1, get a valid consent with unprecedented outcomes. Yes, it is true. You have to go for the, means when you see such a patient in your ward lying who is just waiting for the normal surgery, normal surgical procedures, day-to-day surgical procedures to happen, you have to take a valid consent from the relatives of that patient that there is also a possibility that we may lose this patient. All right. And you explain it to them that this is the reason for that. Second, put the patient on oxygen assistance. Yes, oxygen support is mandatory in these kind of the patient. Then third, prepare the patient for surgery. Yes, this is also true, means you can go for the surgical fixation. That means fixation of the fracture. You can go ahead with that. All right, with unequivocal outcomes. And finally, urine analysis will diagnose the condition. No, obviously not. It will not diagnose the condition. It will just be suggestive of the fat embolism syndrome. So hopefully you get everything which is required at this point of time in order to mark the correct answer related to this question out of fat embolism. So what we have talked about in fat embolism syndrome was the etiology. You came to know the importance of etiology, the clinical features, extremely important for you to make the diagnosis. Then the diagnosis, that no such clinical investigation is diagnosis, it is only suggestive of, and finally the management related issues. All right. So fat embolism is again a dreadful, very serious complication which is preventable to some extent if you start managing the patient earlier in the course of the disease. Then comes the next topic. Although it is not considered to be a complication of the fracture, it is in itself a fracture, but it is because of the complication, it is because of the occupational overuse of the bone. Now the question is, 28-year-old police trainee, now this is the etiology which is provided, comes to OPD with a complaint of pain and swelling in the left foot for the last 1 month. On examination, there was no crepitus. X-ray revealed no fracture. What next? So before we talk about the options, we first of all have to realize